All right, good morning, everyone, and thank you for calling in for our webinar on understanding ACEs and resiliency for better healthcare. My name is Rebecca Valley. I'm a Facilitation and Improvement Specialist with the Patient-Centered Primary Care Institute, which is a program of the Oregon Healthcare Quality Corporation, or QCOR. And just a heads up about some of the interactive pieces for our presentation today before I turn things over. Everyone is and will remain on mute throughout the presentation. We did our best to address some of your registration questions in the presentation, but we do have some time set aside to take additional questions, and we welcome you to submit these via the question pane on your control panel showed here or demonstrated here. Please also feel free to send me, Rebecca Valley, or my colleague, Marissa Sweeney, a message via the questions pane if you're having technical issues, and we will do our best to assist you and troubleshoot that. Please note that we will send all webinar participants a link to the recording, slides, and additional materials after the webinar. These will also be posted to our website at www.pcpci.org. And as I alluded, this webinar is one of many resources that we provide at the Patient-Centered Primary Care Institute, PCPCI. The Institute is a public-private partnership launched in 2012 with the support of the Oregon Health Authority and Northwest Health Foundation, and it is managed by the Oregon Healthcare Quality Corporation, or QCOR. Together with the experts we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model of care. We work to serve practices at all stages of transformation and to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. We encourage you to visit our website at www.pcpci.org to access resources, including previous webinars. You can sign up for our email list on the website, which is how we will announce additional web-based and other training opportunities or institute programs in the future. So without further delay, I am pleased to introduce our speaker for today's webinar, Dr. R.J. Gillespie. Dr. Gillespie is also the medical director of the Oregon Pediatric Improvement Partnership, OPIP. From 2007 through 2010, he worked as the medical director of quality improvement for the Children's Health Alliance, where he designed and implemented QI projects for a network of 110 pediatricians in the Portland metro area. He is actively involved as a member and advisor to a number of local quality improvement initiatives and state policy committees, including the Measurement and Reporting Committee for QCOR, Community Health and Quality Committee for the ALME, the Patient-Centered Primary Care Home Standards Advisory Committee for the Office of Health Policy and Research, and the OHA's Metrics and Scoring Committee, which decides quality and incentive metrics for CCOs in Oregon. With that, I will turn things over to Dr. Gillespie.
Good morning, and thank you everyone for joining us today. This is a project that is near and dear to my heart. In my clinical practice, we've been screening parents for adverse childhood experiences for a little over 3 years. And that started out of some work that I was doing with the American Academy of Pediatrics through their Medical Home for Children Exposed to Violence Project Advisory Committee. And so what I'm going to do today, I have a couple of objectives. I'm going to start by talking first about ACEs and some of the links to poor health in adulthood, and articulate some of the important reasons why we think ACEs should be assessed in primary care, along with resilience scores as well. And then I'm going to spend most of the presentation talking about how I think primary care practices should think about screening for toxic stress in general, and then give an example of what my practice has been doing and what that's been like for us. So it'll start theoretical and then get practical pretty quick, I hope. So starting off with what is toxic stress. And toxic stress and adverse childhood experiences are often interchanged in terms of terminology, but the Adverse Childhood Experiences study came out of Kaiser in Southern California in 1998. And it was a doctor named Vincent Felitti who was working on this particular subject along with Robert Anda from the CDC. He started his work actually in adult obesity clinics and found that he had a number of patients who were very successful in losing weight, and then up to a point and then stopped the program, gained all their weight back, and he was very frustrated by this finding. And so he started doing interviews with some of the people who had dropped out of the program, and found that a disproportionate number of them had been sexually abused as children. And in fact, it was over half of his subjects, his obesity patients, who had that kind of experience. And so he started looking into what other sorts of experiences in childhood might have poor effects on health later on, and found that these 10 different adverse childhood experiences had significant and dramatic effects on lifelong health. And so the categories that he looked at specifically were physical, emotional, and sexual abuse, physical and emotional neglect, and then different types of household dysfunction. So parental mental illness, parental substance abuse, intimate partner violence, divorce, separation, or loss of a parent, and then family members who've been incarcerated. And I think the quote at the beginning of this slide really describes the bulk of his finding. And this was something he found in he was studying 17,000 adults in the Kaiser system. We found a strong graded relationship between the breadth of exposure to abuse or household dysfunction during childhood and multiple risk factors for several of the leading causes of death in adults. And what he found also, he scored the ACE score as being from 0, which is none ACEs, to 10, having all the ACEs. 1 in 5 study participants reported 3 or more ACEs. And compared to a person with an ACE score of 0, those who had an ACE score of 4 or higher were twice as likely to be smokers. They were 12 times more likely to have attempted suicide, 7 times more likely to be alcoholic, and 10 times more likely to have injected street drugs. And in fact, if you look at the leading causes of death in the country, 7 of the 10 leading causes of death in the country can be attributed, at least in part, to adverse childhood experiences. And so the list of risk factors for lifelong health is growing and growing. So not only obesity, which was what he initially looked at, but also heart disease and early deaths from myocardial infarction, alcoholism and alcohol abuse, chronic obstructive pulmonary disease, and on and on and on. And in addition, found that some of the utilization patterns that we worry about in a healthcare system in terms of more ER utilization, more urgent care, more primary care utilization, can also be linked to adverse childhood experiences as well. And what was concerning is that, we think about a lot of this in terms of adopting poor health behaviors, but even if you correct for people who decided not to smoke or not use drugs, the health risks are still higher even in the absence of some of those health risk behaviors. So the heart disease risk is still higher even if you don't smoke. And so these were pretty compelling findings. And in fact, people who had 6 or more ACEs tended to die 20 years earlier on average than those without any ACEs. And so the average years of life lost was significantly greater amongst those people with high ACE scores. And as I mentioned, that increase in risk was only partly explained by documented ACE-related health and social problems. And Robert Anda, who again was one of the co-investigators on this study from the Centers for Disease Control, described adverse childhood experiences as having created a chronic public health disaster. And using the analogy of the Exxon Valdez spill in Alaska, if we had that kind of public health disaster on our hands, there would be all sorts of resources that were being dumped into the cleanup, into the prevention, and into mitigating the effects of those experiences. And yet, it tends to remain still a problem that is under the radar and I think a little under-identified in primary care. We're now at the point where we're 18 years after this study was published, and it's just starting to get traction. One of the struggles I think that came out of that study is that Dr. Felitti, being an internist, was looking at what happened to adults who had experienced those adverse childhood experiences, but what really happens in between the adverse childhood experiences and those adults was a little bit of an unknown at the time, and certainly that created a big scientific gap that needed to be explained. His patients were primarily in their 50s and 60s, and so there was a lot of unknown factors in terms of what led to the health risks once you'd had those adverse childhood experiences. I like going back to an analogy of what would happen if you were walking through the woods and you were to see a bear. And I think we all know what our physiologic response would be. Our blood pressure would go up, our pupils would dilate, and we would be ready to run as fast as we could, or if we had the guts, I guess, try to take on the bear. And our fight or flight response is really meant to be an adaptive response, and our body is meant to tolerate it for about 7 to 10 minutes at a time at the most. And so what happens when in fact the bear lives in your house, or is next door in your neighborhood as a gang member, or is somebody who you have to see at school every day? And how does that chronic activation of your fight or flight response alter your development and alter your long-term health trajectory? And so the American Academy of Pediatrics, a couple of experts, Andy Gardner and Jack Shonkoff, really looked in depth at this particular issue. And I think some of the subtle things that happen during your fight or flight response that you probably don't think a lot about, but the first thing is that if you face a bear in the woods, your thinking brain turns off. And so you don't want to spend a lot of time deciding, can I take on this bear? You know, my fastest pace on a run is going to be about 9.5 minutes. I might be able to do a little bit further or a little bit faster if I really push it. But if you spend time thinking in those kind of stress reactions, then you're going to end up bear food. And so if that happens early on in your childhood, particularly in the first 2 years, that leads to that shutting off of your thinking brain actually leads to poor neural connections in the brain. You also end up with an overstimulated stress response, and part of the overstimulated stress response includes an inflammatory response, because if you're facing a bear in the woods again, one of the things your body is going to want to do is protect itself against infection in case you get injured, but that long-term inflammatory response actually causes physiologic changes within your body and ultimately alters your DNA. That whole line of study is called epigenetics, where we're starting to understand more about how the environment actually turns on or turns off certain parts of your genetic structure. And long term, those poor connections in your brain are going to lead to ongoing issues with managing stress and decision making. That leads to problems with school performance, which ultimately leads to some of the social problems, but then also the inflammatory response ends up leading to a lot of the other health risks as well. And so the CDC came up with this pyramid that is meant to describe how ACEs impact health, and really starts with those adverse childhood experiences. Then you have the neurologic, social, emotional, and cognitive impairment that leads to the adoption of high health risk behaviors, which leads to disease, disability, and social problems, and then ultimately early death. But what we also know, and what we've learned a lot about, particularly over the last 5 to 10 years, is that adverse childhood experiences are really only half of the story, and that there are many factors that can influence how your body responds and how your brain responds to adverse childhood experiences. And certainly not everyone who has adverse childhood experiences end up with the health risks. And so what we're talking about here is what is referred to now as resilience. These are the protective factors that help to buffer the effects of stress and prevent some of the long-term effects. Some of the key protective factors that were identified early: connection with a caring adult, and this is probably the primary resilience factor that needs to be present to help a person resist stress. That is connection with somebody who actually cares about you, who is looking out for you. One of the tricky pieces of adverse childhood experiences is that the bulk of them are committed by the people who are supposed to be your caring adult who is looking out for you. However, if you have an extended family member who provides that kind of connection, or a favored teacher, or a pastor or priest, or a coach on your sports team, then those kinds of people can help to buffer some of those effects. Other protective factors include parental warmth and monitoring, safe, cohesive neighborhoods, and parents without trauma symptoms. Now, that doesn't mean that the parents didn't experience trauma, but they're not manifesting symptoms of those trauma. Ken Ginsberg, who is a pediatrician out at Children's Hospital of Philadelphia refers to the factors of resilience as the 7 C's, and I really like this framework because if you start thinking about the 7 C's, you can start thinking about how we can help patients. Connection, confidence, competence, character, coping, control, and contribution are his descriptors of the 7 C's of resilience. And again, connection being at the top of the list. Again, having a strong connection with somebody who looks out for you and cares for you is going to be one of the biggest factors in resilience and in being able to overcome toxic stress. So jumping into the role of the primary care home and the medical home response to adverse childhood experiences. And just remember, I am taking the perspective of a pediatrician here, and so my perspective on medical home might be a little bit different than some other specialties because I am all about trying to get as far upstream as I can and prevent things from happening in the first place. So you'll see some of that bias in what I talk about. But the American Academy of Pediatrics actually came out with the framework of medical home, and we were the first ones to describe medical home in the late 60s. And initially it was meant to describe how care is provided for children and youth with special health care needs. And so the AAP framework is really conceptual in terms of descriptors that a medical home should be able to describe themselves with. That care is accessible, continuous, family-centered, comprehensive, coordinated, compassionate, and culturally effective. And I think all of these things apply when you're talking about how a medical home would respond to children who've been exposed to violence or to adverse childhood experiences, but two in particular. And certainly family-centeredness is a big piece of it for me. And the descriptor of family-centeredness is that that a medical home recognizes that families play a vital role in ensuring health and well-being of the patient and acknowledge that emotional, social, and developmental support are integral components of healthcare. And the other piece to me is comprehensive, that we're simultaneously addressing medical, behavioral, and social issues and treating the individual as a whole and addressing all of his or her needs. This means that as primary care providers, we really have to break out of the medical model and start thinking about how children develop and grow in the context of a well-functioning family. And so the family is of vital importance for ensuring that children develop and grow in a normal trajectory. The Maternal Child Health Bureau, again getting back to the idea that medical home was initially intended for children and youth with special health needs. The Maternal Child Health Bureau definition of children and youth with special health needs is that they are those who have or are at risk for a chronic physical, developmental, behavioral, or emotional condition and who also require health and related services of a type or amount beyond that required by children generally. And I think the relevance here is that what we know about toxic stress and adverse childhood experiences is that these kids who experience those types of violence meet the definition of being children and youth with special health needs because they're at risk for poor health outcomes. They need additional services compared to other children to help buffer the effects of that stress and to mitigate those effects, and they deserve some sort of tracking and follow-up. One of my colleagues in the Defending Childhood Initiative and Futures Without Violence here in Multnomah County referred to children who are exposed to violence need developmental promotion times 10. So all the things that we normally would talk about in terms of developing a child's or helping support a child's developmental trajectory, kids who've been exposed to violence need 10 times that. They need more connection, they need more competence, they need more coping skills. And so I think it's important to think again as children who've been exposed to violence as being children with special health needs. We tend to have this framework of, somebody who has asthma or who has attention deficit disorder. Those are kids who have special health needs. But kids who've been exposed to violence, again, fit this definition quite neatly. If you break down what medical homes are intended to do in general, if we're thinking about how we do care coordination and support for our patients, the first step is really identifying the population that you need to do additional management for, either through screening or surveillance, and then figure out some way to track them so that you're being proactive in their care. Second step, assessing the family and patient strengths and assets and what specific services they need. Third step, making referrals. Fourth step, providing self-management tools, so helping to empower patients and families to address their own medical or social or mental health conditions, and then following up on referrals to make sure that those services actually were obtained by the family. And so again, I think these are important sort of background thinking about how a medical home should respond to kids who've been exposed to violence. So I've been doing work in quality improvement for about 10 years now, and my first projects were teaching primary care providers how to do developmental screening, and then how to do autism screening, and then how to do screening for maternal depression, and then more recently doing screening for adolescent depression and for adolescent substance abuse. And so screening protocols is kind of my biggest forte, I think. And one of the things that I always think through when I'm implementing or thinking about implementing a screening tool are these 4 questions that I think have to be answered pretty clearly before you embark on a screening protocol. So why am I looking? What am I looking for? How do I find it? And what do I do once I found it? And when you're thinking about screening for toxic stress or adverse childhood experiences, I think it's particularly important to think about the last button, or the last question first, and that is, why would you screen if you don't know what you're going to do with the information? And I think that with toxic stress and adverse childhood experiences, there have been concerns that there's a potential for re-traumatizing families and re-traumatizing patients if we don't have a clear response about what we're doing with the information. And certainly there have been a lot of editorials that have been written in the pediatric literature that talk about the ethics of doing a screening protocol if you're not going to do anything with the results. And so I think whatever people decide to do with screening for toxic stress or adverse childhood experiences, this question has to be answered first. And I think the other piece of what am I going to do when I find it, really in this case has a lot to do with what am I as a provider going to do if I find it? How am I going to keep myself together? And how am I going to stay present for that family as they start talking through their experiences? And I think one of the things that we're all as providers particularly concerned about is that we're going to kick a hornet's nest and we're going to have some kind of situation in our office that we just can't handle and we don't know what to do with. And so I think thinking through that piece of what am I going to do with when I find it is also important. And some of the things that I've picked up over the years that help me to get through these kind of conversations. The first is that listening is therapeutic. And many mental health providers would tell us that if we approach a patient with kindness and compassion, then we will not re-traumatize them by talking about their trauma or by asking about their trauma. And that's a somewhat controversial sentence, but I think that as primary care providers, we have the ability to listen and to be empathetic, and that by itself has the power to help people begin to heal from their experiences. One of my mentors, who is a developmental pediatrician and now works for the federal government, used the phrase, when something becomes speakable, it becomes tolerable. So when you get to a point where whatever your mental health challenge is or whatever your past experiences, whatever challenges you've dealt with, when you start to be able to draw the connection between the emotional brain and the thinking brain, that's the first step towards healing and towards integration. And so being able to speak about your experiences is the first step towards making your experiences more tolerable. For those of you who have been through motivational interviewing, one of the principles of motivational interviewing 101 that I was taught was abandon the writing reflex. And that means that as a provider, we're always of the opinion or the experience that we're supposed to solve whatever problems are standing in front of us. That's how we're trained, that, you know, somebody has a strep throat, I'm going to write a prescription. You know, somebody has depression, I'm going to write a medication, you know, write an antidepressant. But oftentimes with motivational interviewing, when you're trying to help people through difficult changes, motivational interviewing would suggest that the solutions to patients' problems are often founded in the patients themselves. And so helping the patients to discover those solutions and to facilitate those kinds of conversations is very appropriate, I think, in these kinds of settings when you're talking about toxic stress. I think also that it's important for all providers to take care of themselves before they start screening for toxic stress and adverse childhood experiences, because there is a lot of literature and a lot of risk that's been identified around working in toxic stress of what's referred to as compassion fatigue or vicarious trauma. And so we use the analogy of the airplane, that you put your own oxygen mask on first before caring for others. And certainly that's true for primary care providers who start working in this field. You need to be able to think about your own experiences, because many of us have experienced adverse childhood experiences as well. And so knowing how our experiences affect us and what our triggers are is going to be important before we can start talking to our patients with compassion. And then finally, I think that with any screening protocol that you implement in practice, there's a component of education. So when I do a screening tool in my office, there's something that I want my families or my patients to learn. And in this case, I think the main message that I want my families to get is that you aren't alone, it's not your fault, and I'm willing to help you. Steps in trauma-informed care, and I think it is important for practices to think about a practice-wide approach to trauma-informed care. And this means that the entire office staff, from the front desk to the lab to the advice nurse to the medical assistants and the providers, all have thought about the issues around trauma, and that trauma is everywhere, and that you're thinking about that in your interactions with families. I'm a pretty simple-minded guy, so I think about trauma-informed care in 4 steps. The first, individual, and that again is that I'm taking care of myself while addressing the traumas of others. Interpersonal, and that is, can I listen effectively to the trauma history in my patients and my families? The third is organizational, meaning is my clinic a safe place to reveal trauma and address it? And then finally, environmental. Are there community resources or policy tweaks that need to happen that I can use to help patients and families who've experienced trauma? If you're interested in training on trauma-informed care, the Oregon Pediatric Society has put together a very nice 2-hour training that can be used for your entire staff. So if you look at their website, you can figure out how to schedule that. But I would strongly suggest that as one of the steps in screening for adverse childhood experiences or toxic stress, that you think about first training your office in trauma-informed care. So back to those 4 questions, why am I looking? And certainly as primary care providers, once we hear the data about all the health risks and mental health risks that are associated with adverse childhood experiences, I think it's a clear, this is something that we need to do something about. But I think it's important also to think if there are particular needs in your community or in your patient population that need to be addressed. So, I work in Southwest Portland, so I don't have a lot of gang activity in the neighborhoods of the kids that I take care of, so that's not something that I spend a lot of time thinking about. We haven't had, knock on wood, a natural disaster, so that's not the kind of toxic stresses that I'm going to be looking at. But that's something that you would need to think about. What is my community experiencing, and is that something that I need to be addressing as a primary care provider? Also, if there's a specific interest amongst providers to address a particular practice gap or a particular clinical problem that I'm trying to get a handle on. And some of my first surveillance that I did was around bullying, because I was seeing that as a big epidemic, and so that was something that I started asking questions about and doing some surveillance about early on. And then finally, is there an outcome that you're trying to improve? My big passion is making sure that kids are ready for kindergarten, and so that meant that for me, what I wanted to do really focused in the first 5 years of a kid's life. So thinking through these questions, again, will help people to decide, what kind of a screening protocol do you want to actually implement. What are you looking for? So different approaches are going to depend a little bit on the practice readiness and what you're looking for, or why you're looking in the first place. So some people may be looking for specific trauma or specific toxic stress. Other people may be looking at adverse childhood experiences in general. And that colors a little bit whether you're doing universal screening or if you're doing targeted screening or surveillance protocols. Some people, for example, would start by looking at mental health concerns or school failure concerns or somatic complaints, and start asking about trauma in those specific settings as a first way of implementing trauma-informed care into your practice. And then the final question you have to think about in terms of what am I looking for is, are you looking at the patients themselves, or are you looking at families and parents? And generally we talk about endemic and episodic types of childhood violence exposure. And generally the episodic stuff is going to be fairly obvious. And so for the most part, we don't do a lot of surveillance or screening questions for that. That would be, you know, for example, the school shootings that we've experienced here, or the shootings that out at Clackamas Town Center. Those are obvious. They're in the news. You can figure out pretty quickly which of your patients have experienced those things. The endemic types of violence are usually the ones that you're going to want to be thinking through, how do I do surveillance or screening for, because those are usually hidden under the surface. So that first bucket is what most people would spend their time focusing on. How do I find it in terms of deciding an office workflow? This is what visits do you want to ask screening questions, and whether you do the questions as a paper survey or a direct interview. If it's a paper survey or a questionnaire, who's going to distribute it, explain it to the patients, and get it to the provider? And also, how are you going to ensure patient privacy as they answer the questions? And then if it's a direct interview, then you usually have to do some kind of decision support to help you remember the questions. You have to think about how you document the results, and how are you going to maintain respect, privacy, and trust through the whole process. Some people who aren't ready to implement screening tools have suggested a specific surveillance question, and this comes out of the literature, and I use this one a lot for my surveillance in mental health concerns and somatic complaints. Since the last time I saw your child, has anything really scary or upsetting happened to your child or anyone in your family? And I think that's a good general question. There are also on the AAP Resilience Project website, and I have that website in a couple of slides, there are specific surveillance questions that we recommend for individual exposures. So for example, if you're trying to figure out how to screen for bullying, what's the tool for intimate partner violence, and so forth, that's going to be on that website. Some other specific screening tools that have been recommended. There's one that is called the Safe Environment for Every Kid, or SEEK, and I put the link in there. This is meant to be done at the 2, 9, and 15-month visits, and then the 2, 3, 4, 5-year-old visits. And this is a 19-question tool that looks at a brief screener for not only general safety issues within the house, like do you need the Poison Control Center number, or do you need the quit line number for smoking cessation, but then it gets a little bit into food insecurity, into intimate partner violence, and parental or caregiver depression as well. And so this is a nice tool for just general screening within practices. The Survey of Wellbeing in Young Children is another tool that has been developed. It has been used some on the East Coast because it combines not only a screening tool for developmental disabilities, but also for mental and behavioral health in children and family risk factors as well. And it's designed for kids under the age of 5, but there are different age-specific questionnaires for each of those visits. So that website, again, is right there. In some states, they're able to bill the 96110 or the developmental screening code with this. I'm not sure if that's going to fly in Oregon, but that's something that you could certainly look into with your CCO if you're interested in implementing a tool that includes all those pieces. And then some different examples of the ACE questionnaires. I put in a couple of links. One is just the first one is the Find Your ACE Score website, and so it's a one-page with the 10 original ACE questions. The Center for Youth Wellness is Nadine Burke-Harris's group down in San Francisco, and she screens both kids and parents for adverse childhood experiences with different screening tools. And so if you go on her website, you can actually download not only her tools, but also the user guide that she's created for that. And then I'm going to talk a little bit about my screening tool. I had to be careful about sharing it because I have paid to use a proprietary resilience questionnaire, but I'm going to talk about that in just a second. And so what do you do once you found it? First thing, don't panic, right? Keep calm and keep going through your visit. I think that anytime you identify adverse childhood experiences or toxic stress, the first thing you do is assess the child and family safety. Second is figuring out assets, resiliencies, and resources in the family. You may, for the children, need to use some additional mental health screening tools, so the pediatric symptom checklist or a PTSD screener may be required depending on what you're seeing. I also use the SCARED screening tool a lot to assess for anxiety because that seems to be a manifestation of adverse childhood experience exposure. And then figuring out the resources that you need to connect the family with. Where do you get the resources? I think the local child abuse hotline is a great place to start when you're looking for community agencies. Child Protective Services in many counties in the state is doing what's referred to as differential assessment or differential response. And what that means is that the past response for kids who have been abused is to put them into foster care. And it's kind of a one-size-fits-all sort of an issue. But the differential response process would mean that Child Protective Services would be helping get to the root cause and figure out how to support the families and figure out what, if they just need parenting support, if they need education and information, if they need some retraining, which means that Child Protective Services becomes a partner in this. And I think that's an important ally to have. If you don't have social workers in your office, then hospital or health plan social workers often can help you find community resources. There's also the Family to Family Network, which is an organization that tracks family agencies, peer-to-peer type support agencies. The Defending Childhood Initiative and Futures Without Violence have officers in most of the public health departments, so they will have some resources. And in fact, I found a whole lot of resources on intimate partner violence by county through the Futures Without Violence contact within Multnomah County. So that's a helpful thing to think through. And then 211 Info or Help Me Grow. Many of the counties in Oregon are starting to put in 211 Info organizations, which are basically hotlines to help identify early childhood resources. So you can either dial 211, or in some counties there's a 211 Info website. Multnomah and Lane, I think, have the most developed ones thus far, but they also have, as I said, lots of resources for people. The American Academy of Pediatrics has come out with a number of resources. Connected Kids, which is a curriculum for reducing violence exposure. Feelings Need Checkup 2, and then the Bright Futures in Practice Mental Health are both meant to help providers get through some of those mental health assessments and give some counseling and pointers on how to get through some of those complaints in your visit. The Resilience Project is a website that I referred to earlier that has a lot of resources on screening tools, resilience questions. There are some webinars and some trainings that are on there as well that I think are helpful. And then medicalhomeinfo.org, this is the National Center for Medical Home Improvement, which has a lot of tips for how to identify your community resources. Healthychildren.org is another AAP website that is directed at parents, so it has a lot of parenting tips. But also, if you look at the CDC website, they have different positive parenting tip sheets that I actually really like. There are 8 different ones for different age groups that are just sort of quick pointers for how parents can do more effective parenting. So when kids have had those kinds of, when parents have had those kinds of adverse childhood experiences, then those parenting tip sheets are very helpful. So if you're not a pediatrician, the first thing that you should know is that the effects of ACEs can be mitigated no matter the age of the patient. And there have actually been really good studies looking at mindfulness, meditation, and yoga, and how those kinds of mindfulness activities can reverse the health effects of people who have experienced ACEs, which I think is not only an important finding, it's a difficult one to implement into practice, because we have this sort of us-them, I think, mentality with alternative medicine techniques sometimes, but there's something to think about. Trauma-focused cognitive behavioral therapy and interpersonal psychotherapy are both evidence-based mental health modalities, so counseling modalities for people who've experienced trauma. And then I think that if you're in a practice caring for adults and still thinking about screening for intimate partner violence, mental health or substance abuse problems, and food and housing insecurity are going to be important. And still, again, thinking about trauma history and mental health assessments and in your treatment plan is going to be very important as well. So getting into the practice example of what my clinic has been doing, and I'm going to try to go through this pretty quickly. So we have 28 providers. We've been doing a lot of screening protocols since 2008. In terms of our exposure to screening kids for toxic stress, we've had some questions about dating violence and bullying in some of our questionnaires, but not anything that was super specific. And so our theory, obviously raising toddlers is stressful, and there are particular times in an infant or toddler's life that are more stressful than others. Tantrums, colic, toilet training, hitting and biting, and sleep problems would be examples. And so what happens if a parent has experienced trauma, and those sorts of being screamed at by your toddler or being bitten by your toddler, is that going to trigger your fight or flight response? Is it going to trigger a freeze response? Or can we actually encourage people to do something else? And how do we better prepare at-risk parents for inevitable moments during toddlers' lives? And furthermore, if parents have experienced trauma, do they really have the skills or ideas for how they take care of themselves, how to identify when they need help, how to model appropriate conflict resolution, doing discipline that's developmentally appropriate, or in some cases, if nobody actually played with them when they were a child, do they have any idea how to play with their child and thus stimulate their kid's development? And so this is how we sort of framed our screening process. And so if we think about all the parents in our practice, and we know that a handful of them have experienced adverse childhood experiences, for those that haven't, we just kind of go on with our standard anticipatory guidance. For those that have, can we do some sort of enhanced anticipatory guidance where we're spending more time on those kinds of topics like self-care and developmentally appropriate discipline and conflict resolution within the family? And so what we do is at our 4-month visit, parents are given the ACE screener along with a questionnaire about resilience and a list of potential resources. We start with a cover letter that explains what we're doing and what we plan to do with information. We created a confidential field in our electronic medical record that doesn't print into notes, but allows us to see the results when we're in a visit. And we started with 8 of our providers piloting screening, and then spread to the rest of one site, then spread to our second site. And now actually we have all of our providers screening. I had one that was holding out just for reasons of discomfort and lack of confidence, but now we have everybody screening. And I think that's an important thing to think through, that if you're thinking about screening for adverse childhood experiences or for toxic stress, that you start with 1 or 2 providers who feel very passionately about it, who can kind of work the bugs out of the system first, and then also demonstrate to the other providers that it wasn't that difficult, and that you survived it, and that it was all okay. And our first hypothesis with doing this screening, first of all, is just that screening for parental adverse childhood experiences is feasible. In other words, that our providers can do it and that our parents would accept it. And we really wanted to think about provider burden and patient burden in terms of filling out questionnaires as a piece of this. And so this is old data because we've changed our screening process a little bit, but initially we were detecting that about 8% of our families were experiencing 4 or more adverse childhood experiences. The Oregon Behavioral Risk Factor Surveillance System would suggest the number in Oregon should be around 17%, but in our initial test of change, we were getting about 8%. And as the ACEs increased, the resilience score decreased generally, but we saw some interesting low resilience scores even amongst people who didn't have any ACEs that they reported. And so we sort of had 2 theories. If you look at the ACE questionnaire, one thing is that it asks which individual ACEs you've experienced, which can be a little bit difficult for parents to answer and a little bit invasive. But the other is that adverse childhood experience, in terms of those 10 questions, doesn't really capture all the different types of toxic stress that a person could experience. And so we've switched our questionnaire. So instead of asking the individual ACEs, we give people a list of the ACEs and ask them to count how many they experienced. And almost instantly, we jumped from 8% to 13% of 4 or higher, which was interesting. But the other thing that we did is we added in some questions about bullying, racism and prejudice, community violence, and foster care exposure, because those things aren't covered in the ACE questionnaire. And so we're learning a lot about our patients that we didn't know before. But certainly, one thing to think about is that when you ask the individual ACEs, people are a little more reluctant to share the information. Again, looking at old data, this is the first almost 1,500 screens that we did. We did see a discrepancy between privately insured and publicly insured families, which, you know, the original ACE study was in Kaiser adults, and so it was middle-class adults. So the major finding is that ACEs are in all populations, but you do still tend to see a little bit more in the publicly insured population. We also saw a difference between moms and dads in terms of what they were willing to tell us, and there is some literature that would suggest that women are more adept and more willing to tell their story than men, and so I think that sort of plays out a little bit in terms of what population we're seeing. In terms of the providers and how our provider responded, I asked the providers just to fill out a survey anonymously about what their experiences were like. And we asked them some questions that were on a Likert scale, like agree to disagree, and then some that were more qualitative. And then just kind of wanted to get their experience and what they thought was going on within their own practices doing ACEs. And the providers generally disagreed that parents were unwilling to discuss ACEs. That was one of the things we thought was going to happen, that parents were going to not want to talk about it. The providers agreed that ACE screening provided important information for providing care to their patients. They disagreed that time was a barrier, which I thought was really interesting, because I thought that the providers were going to say that that the screening was burdensome from a time perspective. And the provider comfort with discussing ACEs was mixed, and I think a lot of that has to do with how long the providers were in practice. With, providers who've been in practice longer are a little more used to difficult conversations. We've all had those kind of tough conversations in our practice. And so I asked, before you started to screen, what is or what was your greatest fear? Time was number one. Number two was that they wouldn't have resources that they needed to complete referrals, that they were going to open a can of worms or a Pandora's box within the visit, and they were going to have difficult visits that they weren't going to be able to manage, that they weren't going to know what to say, that they weren't feeling confident, that they were going to trigger a full emotional or mental collapse, or that they wouldn't be able to help. And when we asked the providers, first of all, did any of those things happen, and was it as scary as you thought, everybody said no, that none of those things that they were fearful of before they started screening actually happened. And I have even had some of the providers who have said that they were stunned at how easy it was to do this kind of screening. So how has screening for ACEs changed your practice? I have better insight, improved communication with my families. I know the parents better. My office is a safe place to talk about things. More empathy for my families. There's no subject that's off the table. It cultivates a trusting relationship. I have a better understanding of the forces shaping parental responses. So all very, very positive things in terms of what the providers had to say. When I asked them what referrals they needed to do, most have said none. I've had in 3 years 2 parents who I referred to a mental health provider. One, I helped them pick a mental health provider, and one, I referred them back to their primary care provider. But when we ask them what resources they want reading materials and information, they want parenting classes, they want parenting support groups. So all things that as primary care providers we can connect families with. And I think that the other piece of that is that if you're looking at a parent of a 4-month-old child, if they're coming from a place where the one thing that they want more than anything else is to be a good parent, then that is an incredible strength to build on. And that's what the parents were telling us, is that they want information, they want knowledge, they want skills. How do I do this well? And again, that to me is just an incredible thing that I am very eager to support in my families. The providers said that they would never go back to doing things the way they did before, which I also thought was pretty compelling. You know, we've done some screening protocols where after a while people get tired of doing developmental screening or tired of doing a certain screen, but this one they feel like they would never abandon it. The average conversations after completing a screening tool, 3 to 5 minutes is a long one. So many of the conversations are shorter, but of the patients that I've had who I've had a difficult conversation with, and there have been a handful, the conversation still lasts 3 to 5 minutes. And what we usually use as our trigger question after we've talked about parental ACEs on the screening tool is, how do you think these experiences affect your parenting today? The other question that I really like asking is, of those experiences that you had, how many of them still bother you? And of the ones that don't bother you, how did they get that way? And I think what's important about that is, again, really tapping into the idea of resilience and how did parents get through their adverse childhood experiences, and do those resilience factors still exist today so that it's something that they can tap into now? So I'm going to run through a couple of actual conversations that I've had and one that my partners had as well. But generally what didn't happen, we didn't have any hornet's nest kind of experiences. So the first conversation was a 4-month-old infant in for a well visit. The mom's big concern is colic because the kid was spending 3 or 4 hours every night crying. And mom was coming home from a long day at work and then rush hour traffic to a crying infant, and it was stressful. Dad was in training to be a firefighter, so he was gone for 3 days at a time for his training. And then mom was basically leaving work, driving back to home to relieve the nanny. There's nothing else on his physical exam that's concerning to me, and his review of systems, it doesn't look like he has reflux or anything. It's just plain old-fashioned colic. But when I do the ACE questionnaire, mom's score is 5, and her parents had a horrible divorce. There was a lot of yelling and domestic violence in the household. She was yelled at all the time, and so of course a yelling infant has the potential for triggering some of those things for her as well. And so what we started talking about is, how does mom calm herself, and what does she do to take care of herself? And it turns out that before her baby, she used to do yoga a lot, but she didn't have time. And so we started talking about how do you just carve out some kind of 15-minute in your day to recharge and relax and breathe. And what she decided is on her way home, it would be perfectly within her realm to stop at Starbucks and have a cup of tea for 15 minutes and give herself a chance to just get off the hamster wheel. And a couple months later, she was feeling a lot better. The colic wasn't all the way gone, but she was far less stressed, and mom's perceptions were improved. And I think that you kind of got out of that loop of mom's stress feeding into the baby's crying and kind of get this endless loop, which was great. And all I really did was, again, talk to mom about what are some things that she could do to help take care of herself. And I think that the parents often need permission for that kind of self-care because they don't really understand how their own experiences may be affecting how they handle these different situations. The next, and I refer to this as the sleepless household, this is the same kind of situation where the first time the mom brought a kid into me, we weren't doing a screening. Second time we were, and so when mom was talking about her experiences, it turns out her own mother abandoned her when she was 2. Her father then started experiencing depression and alcohol abuse. And so I asked her, how do you think this affects your parenting? And she said to me, well, do you remember with my first kid how you told me to let him cry for a few minutes when he wouldn't sleep? I couldn't do it because I felt like I was abandoning him just like my mom abandoned me. And the funny thing is that, I had struggled with how to counsel her on sleep training for several years, actually, and didn't really have a good idea of why the sleep training was never working until she said that sentence. But the thing is that once she said those fears out loud, she said to herself, well, wait a minute, I'm not abandoning my kid, am I? And so it really helped her to sort of reframe how she felt about sleep training. But we were also able to talk about some other techniques. What's mom comfortable with in terms of training, and then how do we get dad involved to serve as an anchor with a different perspective who doesn't have those kind of fears. And so to me, the punchline was, first of all, just getting the mom to say out loud what her fears were helped her to change her perspective. And she started to be able to heal from those experiences, I think, right at that moment. And then also, I think when our advice isn't heeded or doesn't work, it may not be for the reasons we think. Third case, and I know I'm going through these fast, but this is one of my partners had this case, and this was a kid where we were not screening the kid for adverse childhood experiences, but we were screening other parents early on. But this was really an example of how screening in one circumstance helped people to think through screening in other circumstances as well, or at least having that sort of trauma lens. So this is a teenager who's sort of quietly failing. So we've all had these kind of experiences, I think, where we have a middle schooler or early high schooler who has suddenly grades dropping and isn't really disruptive in the classroom. There's no major things going on that we can tell in the school. He's just not doing well. And he's in a new school this year. He cried about how he hasn't made any friends yet. No thoughts of self-harm. And again, he's just sort of quiet in the classroom, so he's not disruptive or anything. And I think the medical response, if we think about a family that is quote-unquote normal, meaning that the parents are both actively involved in the teen's life, the home life is typical, he lives in a nice neighborhood, then, the sort of things we might think about as primary care providers is, does this kid need a learning evaluation, a sleep history, do they need further mental health screens, are there physical reasons why he might be tired? And so those would be the things we think about from a medical model. But as it turns out, when you get into the history, and this was a new patient, so this was all news to my partner, dad's in jail. Both mom and dad have a history of substance abuse. Parents are divorced. Mom talks a lot during the visit about how she has anxiety and depression and can't quite get her medications right. And this kid used to live with his grandmother, but now that Mom has her act together, he's moved back across town and is not only in a new school, but is no longer allowed to talk to his grandma because Mom doesn't want to be scrutinized by Grandma in terms of her behavior. And so we know before we even get into abuse categories that the kid has an ACE score of at least 4. So now, going back to those factors in resilience, what my partner actually started thinking about is how do we address some of those 7 C's of resilience? Connection is what's seriously missing in this kid's life, right? He's just been cut off from his grandmother. So is this a kid who would qualify for a mentoring program, like a Big Brother, Big Sister program or a school counselor? What sort of strengths and interests and passions does he have that helps get us a handle on confidence and confidence? He really likes skateboarding and he's good at it. So we started looking at boys and girls clubs and some of their skateboarding competitions. We started thinking about coping skills and what sort of things could we teach him quickly. You know, can we get him into youth contact for counseling, but also have him start thinking about exercise and meditation as ways to cope with some of his stress at home. And the punchline really is that when we start screening for toxic stress in any circumstance, it made us aware of ACEs in all the contexts. And really the fundamental crux of trauma-informed care is that you shift your brain from what is wrong with this patient to thinking what has happened to this patient. And if you can do that, you'll start opening your eyes to a whole different way of thinking through patient problems. And then the last one, I did have one mom who's cried so far in 3 years over the ACE stuff. Obviously, I've had parents cry about other stuff, but in terms of the ACEs, only once has this happened. And this is a Hispanic mom with 3 kids, 16-year-old, 5-year-old, and a 4-month-old. And so again, first time that we've done screening with the mom. So when I started talking through the ACE screening tool, her dad was an alcoholic, and she witnessed domestic violence to the point where she thought her mother was going to be killed in front of her several different times. Father was physically and verbally abusive to her and her sister. The mom's sister is married to the same kind of guy, and so she's seeing the pattern repeat itself in her family members. Her 16-year-old daughter, she dropped out of school and was pregnant, moved back to Mexico to live with her extended family. And so she's watching these patterns repeat themselves in her family, and she's worried. And so she cries because she says to me, I don't want to make the same mistakes again. I want better for my children than what I had. And obviously, to me, that's what you would want to see, that, you know, that the parents have recognized their experiences and they're saying, hey, you know what, this is not going to happen to my kid again. I'm willing to take some help on this. And the punchlines on that case, I think listening is therapeutic. And I think most parents come to the conversation about ACEs with incredible strengths despite their past adversity. I mean, she's coming from a perspective of really wanting to do better for her kids. And I think that we deal with parents' emotions all the time, but we don't always have the answers. We just have to know that that we can figure out how to help the family. And again, my key message, you're not alone, it's not your fault, and I will help you. This phrase I stole from one of my partners, one does not need to be a therapist to be therapeutic, and I think that that's really relevant in these cases, that I'm not a therapist, but that doesn't mean I can't help people heal. And I can't, you know, I can certainly help connect people with what they need. What I'm working on now is figuring out some evidence for whether screening for parental ACEs makes a difference in my families. So more to come on that, I think. So in terms of next steps, I think the first step is assessing your practice's readiness to address ACEs. Training your staff and providers in trauma-informed care may help to stimulate interest in some of these issues and getting some of these issues going in your practice. So again, Oregon Pediatric Society has a great training on that you can connect with. And then look at what the screening tools are, and I've given you a couple to think through, and then what community resources you have in your area, and see if there's a match between what your patients need, what you can screen for, and what available community resources are. And then pilot just a small test of change. So like I said, it may be just 1 or 2 providers. Maybe it's just going to be the next 5 patients that you see. You're going to do some sort of screening or surveillance around toxic stress, and then share what you learn with your colleagues. So to sum up, children who've been exposed to violence, I think, and toxic stress can and should be integrated in medical home model of practice. And I think remember to start small and think big. And then Bright Futures has this little mantra that I really like that says, prevention works, families matter, and health is everyone's business. And certainly I think these 3 axioms apply very neatly to adverse childhood experiences and toxic stress. And so with that, if there are any questions, Rebecca, do we take those through the chat box, or how does that work?
Thank you, Dr. Gillespie. Yes, we, at the same way that we showed in the beginning, you can submit questions through the question pane, and we have had a couple come in, and I think you've mostly answered the questions. So first of all, I just want to say thank you so much for presenting, and we're so appreciative of your expertise on such a tough and important topic. So we really appreciate you presenting this morning. We
Sure.
have a question about what about families that don't have four-month-old children? Are you screening for this?
We have not been, and part of it is that we wanted to start small and then sort of see how that spread through the rest of our practice. So what we've started doing is we've started doing some of the surveillance at specific other visits, but we're working right now on doing some universal screening tools that look at, like we're going to be implementing the Seek hopefully on our portal to be looking at some of those other ages if we haven't caught the families at a different time. So for us, this was the big first step, but we are working on some of the other steps that would address other ages. One of the debates that we had was screening kids for their adverse childhood experiences, given that adverse childhood experiences are reportable. And so there's a balance between sort of the mandatory reporting and the building trust and confidentiality with the families. And so Multnomah County is going to be the last to do differential response, and I think once that is there and we know we can count on Child Protective Services to be a partner in terms of helping us get to root cause, then we will look at that differently. But for right now, we're moving from the screening that we're doing now into doing the Seek for our population, which gets, I like that as well because it gets into the food insecurity and some of the other pieces that kind of hit on current issues that we need to address.
Okay, thank you. And I really quickly want to say to other folks, we are just 1 minute past 9, so if you do need to leave, please feel free to submit questions to info@pcpci.org if you have further questions that we're not able to address. But Dr. Gillespie, if you just have a couple more minutes, there are a couple of questions that came in.
Yeah, and just one thing I'll say real quick too is that I do sit with practices to help them figure this out. So if you have a practice that's interested and you want some more direct one-on-one help in terms of figuring out how to do the screening, I'm open to that. So just keep that in mind before people log off.
Okay, that's great. Thank you. Okay, so we might be sending people your way then.
Sure.
So we had a question about assessing practice's readiness to address ACEs. Is there a specific assessment tool that you use, or are there questions that you ask to determine a practice's readiness for this?
Yeah, there isn't a specific, I mean, there are assessment tools around trauma-informed care and how trauma-informed are you, and I can find the links to that and get that. You said you were going to put some stuff on the website, so I can find that for you. And so that's one piece of it. And then the other piece really has to do more with provider willingness and interest and engagement. And I think that one of the challenges that we've had in terms of keeping this going is that we're trying to have this screening come to life in the middle of an ICD-10 conversion and meaningful use attestations and everything else, and so it sort of became a low priority for some of the providers, which is I think a piece of why I didn't have everybody screening all at once. And so there's some more subtle, like non-assessment tool related factors that you have to think about. How interested are your providers? How overwhelmed or burdened are your providers? And then there are, again, some assessment tools looking at trauma-informed care and how far along are you on that spectrum. And that tool I will look up and get to you.
Perfect, thank you. And last question about screening for adopted or foster children at a young age when parents or family members are no longer involved. How does one go about doing that?
Yeah, and that's a tough one because it's sort of going to depend on how much the foster family even knows about what the background situation was. So I don't have a good answer for that, but I know that HealthShare has done is doing a learning collaborative on toxic stress within foster care families, so I can figure out how to connect people who have that specific question to the people who've done that learning collaborative, if that would be helpful. they would probably have a better answer on that than I do.
Okay, that's fair, and thank you. As Dr. Gillespie mentioned, I will be posting these links to these resources that we've talked about on our website, and I just want to thank everyone again for their time this morning, and thank you, Dr. Gillespie, for sharing your expertise and in such a fantastic presentation. So with that, please fill out your post-webinar survey and have a great rest of your week.
Thank you, everybody.
Okay, thank you.